Hi, this is Dr. Max Fung, Director of Dermatopathology at the University of California, Davis in Sacramento, California. This is the annual introduction and orientation for incoming dermatology and pathology resident physicians. Please check our website for the annual teaching schedule, and please feel free to leave feedback or comments. So, dermatopathology. Some say dermatopathology, or how about just Dermpath? It's a relatively subspecialized area of medicine dedicated to the diagnosis and management of skin diseases via the microscopic evaluation and increasingly submicroscopic evaluation of lesional skin tissue. And unlike other highly subspecialized areas in medicine, Dermpath is not a new field. In fact, the modern day foundations of the fund of knowledge in Dermpath were created by physicians and scientists from many disciplines dating back to the 19th century at least, with predominant contributions from pathologists and dermatologists over the past century or century and a half, the likes of Savat, Gons, Curley, Pincus, Father and Son, and Paul Una. I particularly remember Dr. Una because I have a photograph of him on the wall in my office that was given to me by one of my former dermatology residents, Dr. Errol Craig. And in fact, Dr. Una was regarded as arguably the top dermatologist in the world in the early 20th century. He was the first to describe seborrheic dermatitis. He also described one of the types of melanocytic nevus, and you may also be familiar with his famous boot and his famous paste. But as you can see, in order to do an authentic history dive here, you do need to be able to read some European languages. My personal experience as a Dermpath history dilettante, emphasis on the latter, was facilitated by the first comprehensive US Dermpath textbook that was published by Dr. Walter Lever when he was a fifth-year dermatology faculty member at Harvard in 1949. This is Dr. Lever in the framed photograph when he visited UC Davis in 1977 as our Novi visiting scholar. Standing to Dr. Lever's right is Dr. Larry Bass, the founding chair of our dermatology department at UC Davis. Lever's, I believe, remains the most comprehensive US Dermpath textbook, now in its 11th edition. And I guess at this point I should say with pride that I do have a small scholarly conflict of interest here because I did co-write one of the chapters in the 11th edition. Not financial though, I wish. I'll talk more about tissue staining and special stains in that intro lecture, but suffice it to say here that the accidental discovery of hematoxylin as a tissue stain in the 1800s, followed by the creation of eosin, and soon after the discovery of the hematoxylin and eosin, or H&E double stain, revolutionized the field of pathology and essentially formed the foundation of anatomic surgical pathology as we know it, including Dermpath. And it would be a vast understatement to say that this technology has stood the test of time, like a century and a half, and still going strong. I attribute the longevity to a winning combination of its superior ability to discriminate fine details within tissue specimens, combined with its rapid turnaround time and cost effectiveness. The 1970s and 80s saw rapid adoption of immunohistochemical stains, or IHC, as an ancillary diagnostic test, and in many cases essential for diagnosis. And we're now seeing increasing reliance and availability of molecular diagnostic testing. Skin specimens are obtained by a wide variety of doctors and providers in a variety of settings, but the dermatology clinic probably represents the single biggest source of skin specimens. The Dermpath waiting room is quite a bit more compact. Wet tissue specimens and prepared slides arrive daily. And sometimes it seems like we're more of a five-star hotel or a medi-spa because our courier in her hybrid vehicle personally picks up and diligently transports each of the specimens to their appointment in the Dermpath waiting room. One by one, each specimen is accessioned, grossed, processed, embedded, cut, and magically slides appear on our desks, and the doctors in training view them under the microscope, and render an interpretation. So in rendering a diagnosis on case after case after case, pathologists wield great responsibility and power, and that is par for the course in traditional surgical or anatomic pathology, AP, where histology is the diagnostic gold standard for most tumors, including skin tumors. Clinical correlation is still essential, and of course, with any technique, there are limitations. So some cases are simply challenging and beyond the range of what H&E can resolve. Alternatively, if one is perhaps asleep at the wheel for even just one case, there's a potential to make an error that could potentially result in patient harm. Sometimes a technical error could be quite significant, a wrong or a switched specimen. And then finally, we mentioned ancillary diagnostic testing, which can be decisive in certain cases, but typically the decision to test has to be recognized as being indicated based on the H&E. The other side of dermatopathology are the skin rashes or inflammatory skin disorders, in which the gold standard for diagnosis is not just the pathologic diagnosis, but rather a clinical path correlation. So one must know one's clinical derm. And molecular studies are playing an increasingly prominent role in the entire field of pathology. It's been said that such studies may even replace H&E entirely within the next few decades. This being a quote and also a photographic tribute to the first person who taught me dermatopathology as a second-year medical student and then later as a dermatology resident, Dr. Phil Lebois, founder of UC San Francisco Dermatopathology Service. As of 2020, we're still able to render a definitive or at least a useful diagnostic interpretation based on H&E alone, with occasional assistance from special stains. Of course, later in 2020, business as usual changed, and Dermpath education was no exception. One last word, or actually one last image for now, on the advent of molecular diagnostics. Is this just a bad dream? Or will someone's Nobel Prize be the end of the Dermpath world as we know it? Although Dermpath and H&E have been around for well over a century, the subspecialty is still relatively small in terms of full-time practicing dermatopathologists. UC Davis Medical School was founded in 1966, and it was not until '86 that Dr. Ronald Barr was recruited as chair of dermatology with a primary focus in Dermpath. Joining him was the late Dr. Philip Vogt, who stayed here for the rest of his career. After that, we had the amazing Dr. Beth Rubin. I arrived in 2002 and started the Dermpath service as we know it today. And of the 7 full-time dermatopathologists at UC Davis, 3 of them are still your attendings, myself, Dr. Thomas Konia, and Dr. Maya Kiuru. We also have an affiliation with the Veterans Affairs Hospital, where we have Dr. Joshua Schulman, an amazing teacher. We also have volunteer teaching from dermatopathologists in private practice at Diagnostic Pathology Medical Group. And there are many dermatopathologists who are board certified but not primarily focused on Dermpath. One of those is Dr. Peter Lynch, former department chair and distinguished Novi professor and program director. And Dr. Lynch was the one who kindly donated some of his older dermatopathology textbooks to me when he retired. The dermatopathology service is located in the Department of Dermatology, a few miles away from the main hospital and the medical center, in the Cannery Business Park in East Sacramento, across the street from the Roxy Deli that was featured in the movie Lady Bird. Heading inside, the good old days. This is how we used to do it, like most people did, with most of our teaching sessions occurring at our 16-headed teaching microscope. It's quite different now in the pre-vaccine pandemic era. In-person previewing of slides, a traditional workhorse of pathology medical education, is now optional. And when in-person previewing is done, we must follow the distancing guidelines as well as wiping down the microscope before and after use. This is a closer view of our 16-headed scope, and I've surmised that there can be a maximum of 3 users of this teaching scope at the same time in order to maintain distancing. Something like this. We have additional microscopes in the teaching room that would permit an additional 1 or 2 viewers in parallel for a maximum of 5 in the room. But again, previewing is optional. If you do elect to preview, please be sure to wipe down the microscope before and after use. And we never had to think about this before, but these are some of the areas that you normally would touch when you use a microscope. So we have these wipes and gloves in the room that are available to use. You're going to have to focus. You push glass with or without a slide holder. You're going to touch the objective and the turret. Your eyes and face are going to be in this area. And then there's just the whole kind of workstation area around you. And so anytime you do live previewing, it's going to have to be a somewhat flexible situation. It depends on your individual and the group situational awareness, just like any clinical setting. Our Dermpath service uses 2 different lab reporting systems. For UC Davis cases, we have the Beaker lab reporting system, which is part of the EPIC EHR. And then for outside cases that come from outside UC Davis, we have a separate system supported by NovoPath. We have 2 corresponding accessioning wheels. So the UC Davis cases have a DC designation, whereas the outside cases have a DS designation. I feel very blessed that I've worked consistently with very conscientious and responsible colleagues and trainees. The one housekeeping thing to remember is that these little 1 by 3 inch glass slides are easy to move around, but just remember that they're part of the patient's medical record. And unlike the electronic records, they are essentially irreplaceable. So if you do need to take slides out of the Dermpath unit for whatever reason, please just check in with our admin staff and they can prepare a tissue release form for you. All of the recent slides are filed in the teaching room, so you can access those yourself to review for study purposes or whatever. And when you're done with them, there's no need to try to refile them. Please return them in this space behind the admin desk. Biopsies obtained on critically ill patients in the hospital or the emergency department are considered rush orders, and our lab will generally recognize when that's the case. But when submitting such a specimen, if possible, please write rush on the order. If possible, please make a personal handoff to a lab staff if you happen to see them when you're in the lab. You can always call the main desk or the lab directly and give them a heads up that a specimen is coming. And because infection is frequently in the differential diagnosis for these patients, it's not uncommon to pre-order special stains for infection if deemed necessary. So if you write that on the order, that will facilitate turnaround time as well. We have a bin in the lab where these specimens can be placed that will facilitate their top priority. Weekend and evening stat frozen sections are covered, and they're actually covered 24/7 as needed by the Department of Pathology. The pathology residents should have the details in their resident policy and procedure manual. And this introductory lecture, when it was in person, used to be the first chance that you would get to see the people that you'd be working side by side with in the evenings or after hours when you had a stat case. Now, sometimes when a stat case happens during normal business hours and Dermpath is open, we're happy to handle that stat frozen section as well. Just call Dermpath, and more often than not, we'll be able to take care of that slide preparation. Your welcome packet includes a Dermpath grossing manual at the end, and in that you'll see that the shave, punch, and excision specimens are the most common specimens submitted in Dermpath. The shave and the punch biopsies are relatively small specimens that can usually fit in a single cassette on a single slide, whereas the excisions and occasional incisional biopsies are usually submitted in multiple blocks sectioned in red loaf fashion. In the old days when I was a resident, and maybe still true at other programs, the residents on rotation were expected to gross the specimens. That's not the case in our program, but it's still very valuable to understand how specimens are grossed in the lab. So if you have interest in seeing that, just please contact one of your attendings and we'll arrange for you to observe one of our grossing technicians. When you're on the Dermpath rotation, you spend most of your time at the microscope, so sometimes it almost seems like the slides just kind of magically appear there. But in fact, there's a lot that goes on behind the scenes, not just the grossing, but several steps after that. So this text here is just a little bit of a snippet from the grossing manual that's been provided to you, and it just attests to the fact that there's a critical importance of accuracy at every step along the way, specimen after specimen after specimen. We have a team of highly skilled technicians working, sometimes it seems nonstop behind the scenes to get these slides to us promptly and accurately. Hats off to them. More snippets from the grossing manual that I won't dwell on since you have it. Although I have to say, looking at this, that I do see some of the words of wisdom from Dr. Philip Lebois from UCSF. He gave me a similar grossing handout when I was a dermatology resident there. Punch biopsies may be in a wide range of diameters. Probably 4 millimeter is the most common, but as you can see, there's a wide range. Whenever possible, we do prefer to bisect the specimens so that we don't lose any tissue and that the initial sections will be from the center of the specimen most likely representative. Grossing guidelines for shaved specimens are similar to the punch biopsies. Shaved specimens could be shave removals or shave excisions, in which case we would typically add ink to better assess margin status. The glass slide on the upper right shows breadloaf sections of an excision specimen. You can see the tumor at gross power in the top two pieces of tissue there. And the grossing diagram shows a top view of an excision specimen with the vertical black lines indicating the locations of the breadloaf sections. Typically, we put the excision tips in a block, and as you can see, B and C would be a second and a third block of this specimen. If the specimen was submitted with the orientation, such as a suture or a hash mark, then we would use 2 different colors of ink in order to preserve that orientation in the event of a positive margin. And less commonly received is the incisional biopsy, but it's worth mentioning here. These specimens may be an identical size and shape to an excision specimen, but in this case, the clinician is not looking for margins. It may be a portion of an inflammatory disorder, often a paniculitis or morphia. And so in that case, we don't need breadloaf sections. We don't need ink for margins. What we want is really just the best tissue sections that we can get. So these would actually be sectioned longitudinally so that we get single large tissue specimens as opposed to multiple breadloaf sections. Makes for pretty viewing and nice photomicrographs in the event of publication. Let's start to conclude with a few comments on your learning. Of course, you'll be continuously training through the Dermpath curriculum through your residency time here, but let's start with some of the resources that are available. And hopefully to you as digital natives, you won't find the potential for information overload here quite as whelming as a digital immigrant like me would. There's no shortage of dermatology, pathology, and Dermpath textbooks. Some of the ones listed here are just scratching the surface. Increasingly, as you can see here, some of these resources are online, and pretty much all of these textbooks generally nowadays have online versions for you to study from. And as I alluded to before, unfortunately, I do not have any financial conflicts of interest with any of these. I did write a few chapters in some of these books, but that's the extent of it. And currently, our program is providing the Elston and Faringer textbook here, this one right here. And so that's what the dermatology residents are starting with. But I find that many trainees over time then expand to other textbooks, depending on your level of interest. If you find yourself wanting to learn more about Dermpath, maybe even thinking about a possible fellowship application, it's a good idea to stay on the cutting edge of the field by reading the journals and participating in the Dermpath societies. The 2 largest journals are the Journal of Cutaneous Pathology and American Journal of Dermatopathology, and both journals are sponsored by societies who also hold national and international meetings in dermatopathology. Unfortunately, the upcoming ASDP meeting was converted to virtual, so we'll see how that goes. This is new and uncharted territory. The live meetings for ISDP in 2021 are still a go, pending further developments. We have hard copies of both of these journals in the teaching room in our Dermpath unit, and both are available through the UC Davis library as well. I think I've had some version of this slide in my introductory lecture probably for at least a decade. But I like to put this up at the beginning of the year because we have incoming trainees and also trainees who are graduating to the next postgraduate year. And I think it's an appropriate time as any to think about yourself, think about your training, your goals, your aspirations, and see how that might fit, whether that be Dermpath or some other area of dermatology or medicine. But here's some details of what could be construed as a hierarchy of competence in dermatopathology. And of course, I put a question mark there because there's not a whole lot about this that needs to be rigid. One could say very little about this or discuss it for hours. So that will happen in the Zoom session afterwards. But at a minimum, as a dermatology or pathology resident, you are expected to pass the dermatology or AP boards. And as you surely know, the Dermpath component exists in both. So that's the minimum. Everything else is extra on your own, but there's lots of different things that can be done. If you complete a fellowship, then it opens up other opportunities. These are things that we can discuss individually or as a group in the Zoom meeting. And as we segue to the virtual discussion, I'm going to leave you with 4 scenarios to think about and discuss with me. I won't read them. You can look at them as fast or slow as you want. But here's the first one. Here's the second one. Here's the third scenario for discussion. And finally, the last and perhaps most philosophical one. So I hope you found some useful information and resources from this introduction. Your Dermpath attendings here are very passionate about telling, showing, and involving you in the wide world of Dermpath. And we know that you'll forget some things, but also that you're going to remember and learn.